So today we have a presentation. We're trying to get back to a once a month sort of thing, but it's a little harder to do because their schedules have been changed a couple of times in the last year, and it doesn't all come out the same. Um, we so we do try to do it though regularly, where the resident physicians can have this experience, and hopefully a good one for the audience as well, of leading some healthcare education. Uh, and the what we talked about is the indicator of success, and that is that you, our audience, understands, because we put it in lay terms that a person can understand. To just snow you with a lot of technical terms wouldn't be very effective, and in fact be the wrong thing to do. I hope you agree with that. The two doctors leading the charge today, Dr. Guyo, Dr. Zeytun Guyo, and Dr. Idean Pourshams have not only been out here on rotations many times, they're both third-year residents. So we have a 3-year internal medicine postgraduate education residency program, and they're in their third year. So at the end of the academic year, often May or June actually, they'll be heading out to do other things. And I thought I usually give a little introduction of what their name is and where they're from and so forth. I thought I'd let them do that. Just something short about yourself. Who would like to go first? You, yourself, your family.
Hello, how are you? Yeah, my name is Zeytun Guyo. I'm originally from Kenya. I came to attend college in Little Rock. I attended ULR, and then subsequently was accepted to UMS, and I am doing my residency up here. So, yeah.
And for those of you who don't know me, my name's Idean, and I grew up in California. My family's from Iran, and I had a career before medicine, but I'm so glad that I started studying medicine, and now really enjoyed. I can't believe it's already the third year, but really have enjoyed my internal medicine residency training here. I'm a little sad that it's going by so fast, but I did apply for a fellowship here in town, so hopefully that'll work out, and I'll see you guys for another year at least. But it's been great to be here.
That's great. So y'all were both experimenting, you not using a mask and you using a mask. Could you hear him well enough even with the mask? As long as we got the, as long as you speak into the microphone, great. Thank you both for sharing that with us. So today we have a subject that we've covered before, but it's been a few years. But it happens to be one that people know the word, and often from personal experience with family or friends or themselves, know a thing or two about, and that's congestive heart failure. I have to tell you, I really don't like the term. I think we could have done better than congestive heart failure. If a person doesn't already know a lot about it, it's tempting to hear failure. The heart has failed, and in fact, some people equate it to a cardiac arrest, which is totally misleading. It's you're going to hear the details of how heart failure, as we want to present it today, is something that is treatable, not always curable, but treatable, and it simply means the heart is failing. The heart as a pump is failing to pump efficiently enough and effectively enough to pump blood forward in an efficient way, and so it backs up into other organs. And so I think they will give you a pretty clear explanation for that and how many different ways that can show up. Who would like the microphone first? Dr. Guyo.
All right. So we'll try to understand signs, symptoms, and management of heart failure. Next slide, please. Oh. Okay, so yeah, it's okay. So the heart is a pump, if you want to think about it that way, that moves blood throughout the body, and that supplies oxygen to every cell in our body. So what does heart failure mean? Heart failure means that there's failure of the pump not working as well as it should be. So there are two main types of heart failure. Either the pump is weak or the pump is stiff. So we typically do an echocardiogram, which is an ultrasound of your heart, to determine what we call an ejection fraction, which is how much blood your heart can pump out. And depending on that number, typically anything greater than 50, we consider the pump function preserved, and that is called the heart failure with preserved ejection fraction. And then if that number is less than 40%, then it's a HFrEF, which means heart failure with reduced ejection fraction. And that basically translates to the fact that your heart cannot squeeze hard enough to deliver that blood to all the cells in your body. And stiff pump means that it's mostly relaxation issue. Your heart cannot relax well for it to fill up with blood and subsequently pump throughout your body. All right. All right, so as I've mentioned before, the two types of heart failure. So this is just, going into depth with that. So common causes of heart failure include prior heart attack, coronary artery disease, meaning, the major arteries that supply your heart could be clogged. And then also some dilatation or rather cardiomyopathy can also contribute to heart failure. So, but there are medications that help us sometimes improve the function of the heart. So there are four main categories of medications that we put patients on, and we titrate it to maximum tolerated dosages. We'll go in detail towards the end about these medications include beta blockers, ARNI, ACE or ARB, MRA, and SGLT2 inhibitors. So I went a little bit over HFpEF, which is heart failure with preserved ejection fraction. So here the ejection fraction is how much your heart can pump out would be greater than 50%. Some of the causes are high blood pressure, diabetes, obesity, and old age. So the main treatment for this kind of heart failure is your diuretics and also SGLT2 inhibitors. These medications, for example, dapagliflozin has been shown to reduce mortality as well as hospitalization. It's great for heart failure with reduced ejection fraction, preserved ejection fraction, sorry. So when our heart fail, there are many compensatory mechanisms that, the other parts of the body take over to help the heart pump. So your nervous system, especially your sympathetic nervous system, produce a hormone called adrenaline that helps, speed up the heart and also compress the blood vessels to help your heart pump out more. And then your kidneys also help. They absorb more salt and hold on to water. And all these are compensatory mechanisms to help you, increase that cardiac output. But some of these compensatory mechanisms over a long course of time are not good for us. For example, when the kidneys hold on to all that water and salt, you end up with lower extremity swelling, sometimes even swelling in your body wall. And then also there's all this fluid around, so it backs up into your lungs, and you get what we call pulmonary edema. But as I mentioned before, those 4 pillar medications can help with these adaptive, or rather maladaptive techniques that our body goes into. So I did mention a little bit about some of the causes of heart failure. The main cause of heart failure is called ischemic heart disease. And this is basically translates to there are arteries on your heart. Your heart is a muscle, and there are arteries on it that help feed the heart. And once some of those arteries get blocked, then it translates to what they call heart attacks, especially if it's completely blocked. So that is a major cause of heart failure. And then hypertension is also a major cause of heart failure. And that's why it's important to optimize blood pressure to help protect your heart. Also, what we call valvular heart disease. You can have stenosis of valves, including different valves in the heart, mitral valve, aortic valve. Also, you can have what we call regurgitation, so leaky valves. And then also abnormal heart rhythms, for example, atrial fibrillation, A-flutter, all these contribute to heart failure. Other things that cause heart failure include alcohol, drug use, for example, using methamphetamine. Some other causes of weakened heart muscle or cardiomyopathy include, genetics. For example, HOCM will be in that category. And then some other conditions such as diabetes, which causes macrovascular dysfunction, can contribute to heart failure. Thyroid disease, obesity, and also some lifestyle, such as drinking alcohol, can also cause heart failure, drugs, and smoking. So why does prevention matter? When we catch heart failure at an early stage, then we can make necessary intervention to help prevent from progress, to help it prevent from progressing. Also, when we add these medications, the 4 pillars we mentioned before, we can help keep you out of the hospital. We can protect your heart from more damage and help you live longer, and also overall improve your quality of life, and as well as your overall length of life. So some of the symptoms, most common symptoms of heart failure is shortness of breath, especially when you exert yourself. Swelling, typically in the lower legs, extremities, You may notice rapid weight gain, 2, 3 pounds over the course of maybe a day or two. You may be more tired than usual. You may also cough, wheezing. We talked about that fluid backing up into your lungs. It can cause some of these symptoms. And then needing more pillows to sleep, inability to lay flat is something called orthopnea. All these are some symptoms of heart failure. But it may be different in the older population. So some of the symptoms among older adults include poor appetite, confusion. You may experience lightheadedness and falls, or maybe your shoes no longer fits, or your clothes may become more tighter than normal. And then you may also experience that nighttime awakening. You may catch yourself gasping for air at night, in the middle of the night. So these are the most common symptoms in the older population. So this is just basically a recap of how it can show up, fluid buildup, and then getting more tired, cough, inability to lay flat, and then sometimes you may feel bloated or nauseated, and confusion, especially in older women. The presentation tends to be different. All right, so these are some of the red flags, if you will, and when you should seek help in case you have, heart failure, severe shortness of breath, fainting spells, chest pain, especially chest pain when you exert yourself, weight gain, coughing, sneezing, and just getting more tired and inability to take care of yourself. So how can you take care of yourself when you have heart failure? You can weigh yourself every morning. Most cardiologists or your primary care physician will check your dry weight versus your other weight, and then you compare those two weights and see how much weight you've gained, and then you continuing to check for swelling, and then listen to your breath and yourself, and take your medications as prescribed. Watching for salt and fluid intake can also help. I will turn it over to Idean for the next session.
Thank you, Zeytun. Zeytun, of course, started off so strong. I wanted to clarify something. When people talk about ejection fraction, is everyone clear on what that means? Okay, so imagine there's a certain volume of blood in the left ventricle, which goes out to the rest of the body. And of that volume of blood, a certain percentage is pumped each time the left ventricle squeezes. And that gives you a fraction, your ejection fraction. So it's not 100%. Not all of that blood is being pumped to the body from the heart. But normally 50 to 65% would be pumped. And if that's low, that's indicating that the pump is not pushing hard enough, okay? If it's normal, it also doesn't mean that it's always safe. You might have diastolic heart failure, and we'll try to clarify that step by step. But if you have a lower volume of blood to begin with, and you still pump 60% of that, it's still insufficient. You're still not pumping sufficient amount of blood to the systemic blood flow systemic circulation of the body. So I just wanted to clarify that. And the reason that happens is if the walls of the heart start to thicken because of heart failure, congestive heart disease, and the walls are thickening, that leaves less volume space in the heart to fill with blood to sufficiently pump blood out of there. So when they talk about heart failure with preserved ejection fraction, they make that into a word called HFpEF. The preserved ejection fraction doesn't mean that you still have preserved the adequate amount of heart function. You could still have heart failure even though the ejection fraction is preserved. And then the other term, heart failure with reduced ejection fraction, is indeed when the ejection fraction is low and you're not sufficiently pumping. I hope that clarifies it, but we can discuss it more. I'm going to talk a little bit more about what we can keep an eye on if a patient does have heart failure and what the different treatments are. So as Dr. Guyo had mentioned, we look for swelling in the lower extremities that indicates that we're not circulating sufficiently. That blood can, that lack of circulation can also fill to come to a point where we have congestion in the lungs, and we also see symptoms of congestion in the liver as well. So everything the flow kind of backs up into the lungs, the liver, and these are the signs of congestive heart failure. Because we have that congestion, patients can develop shortness of breath as well. Not only because we're not getting an adequate circulation of oxygen through the body, but you're also getting a backflow that's causing pulmonary congestion of the lungs and swelling in your legs as well. And that's why salt and fluid has been discussed. The recommendation is 2 to 3 grams of salt a limitation of sodium intake, 2 to 3 grams, and then fluid intake up to 2 liters to try to minimize that consumption and that accumulation of fluids, especially if the patient is already taking a diuretic. Let's go to the next slide. We're going to talk a little bit about the medications. So here again, these are some suggestions. Instead of using salt, to use herbs and lemon juice. And then rinsing your canned foods because there might be a lot of sodium in there. And with education, patients get better at this. Celery, for example, is high in sodium, and patients need to be reminded of that. They might think that they're being healthy to eat raw celery, but that itself has a lot of sodium. We can go to the next slide. Despite any problems with heart failure, it's always recommended to continue staying active, exercising, continuing movement, including stretching, even light walking is beneficial. And I think the next slide we'll talk about some of the medications, and I'd like to discuss how they work. So we could go to the next slide too. Another reminder, if a patient is smoking, definitely needs to stop that as well. But we're focusing a lot on sodium, fluid, and now looking at some of these medications. We had mentioned the diuretics, which indeed try to minimize the amount of fluid load on the heart to prevent that congestion. And besides the diuretics, some of them you may have heard of, like Lasix, spironolactone, aldactone. These are all different diuretics, most of which cause potassium and sodium to be lost in the urine. But spironolactone is an option if the patient is having a very low, critically low amount of potassium. We have some options that try to retrieve potassium in the kidney system. Other medications include ACE inhibitors, which is angiotensin converting enzyme inhibitors. And what that does is try to prevent a clamping down, or how can I put it in layman's terms? But we want to dilate the vessels rather than tightening them. And these medications work on the arteries, the arterial system, including the kidneys, to try to relieve the pressure on the entire system. So both the angiotensin converting enzyme inhibitors and the angiotensin receptor blockers, the ARB, they are all designed to try to relax the vasculature, the circulation, to relieve the high blood pressure. Beta blockers are another example of the medications which essentially will either slow down the heart rate and reduce the blood pressure, and the mechanism of action focuses on the adrenaline and mineralocorticoid system to try to also diminish the strain on the heart, both with the rate at which it's pumping and the overall blood pressure of the system. And then the SGLT2 inhibitors were developed to try to control diabetes. These are medications that include semaglutide, for example, and they were developed in an effort to control diabetes and obesity, but during the testing phases, they had to make sure that it was safe for all the patients. And what was noticed was that not only was it safe for patients with cardiac disease, but it had a beneficial side effect, to the point that it not only was safe, but it decreased mortality and it improved cardiac function. And now these are medications that are prescribed for heart failure, whether the patient has a diabetic component or not. The other medications include hydralazine, isosorbide, and digoxin. These are medications that either can decrease the blood pressure of the cardiac system by dilating the vasculature, or helping, if the part is not pumping sufficiently, they can have an inotropic effect, which is to increase the function of the heart with each pump, to pump more effectively. We can go to the next slide. So when our patients are on diuretics or these water pills, the weight is very important. We ask the patients to weigh themselves daily, and if there's a acute change, like 2 or 3 pounds in a day, we kind of ring an alarm. We either give an additional dose of the diuretic, or if we have a lot of concern, we just tell the patient to go to the doctor. So 2 pounds fluctuating in a day or 5 pounds in a week are really points at which we start having some concern about the increase of the water retention. Okay, we can go to the next slide. As mentioned, these angiotensin converting enzyme inhibitors and the receptor blockers, they relax the blood vessels, and in doing so, they protect the kidneys and the heart. They are medications that are proven to improve survival. And one of the side effects that you may have heard of for the ACE inhibitors is this dry, nagging cough, to the point that if a patient is started on an ACE inhibitor and they have this annoying cough, dry cough, we just discontinue that medication and try an angiotensin receptor blocker instead, which apparently does not have that side effect. We can go to the next slide. And the beta blockers, as mentioned, these are medications that work on the mineralocorticoid system, and they're able to not only slow the heart, but also effectively try to reduce the strain on the heart and the blood pressure. Overall, improving heart function and also improving mortality, and, decreasing mortality, increasing the patient's chance of survival. This side effect of tiredness I wanted to mention, especially if patients are trying to exercise on a beta blocker, their heart may not respond to the activity, to the exercise, to the point that they're having a little bit of exercise intolerance, some dizziness, some sluggishness. So a lot of patients may not tolerate the beta blocker very well because of those side effects, especially if they're trying to stay active. They can go to an exercise class or to the gym, and their heart is just not keeping up with the activity because it's keeping the heart rate slow when you would expect it to speed up to sustain the higher level of activity. We can go to the next slide. So these are the spironolactone and eplerenone were mentioned earlier. Spironolactone is a diuretic that retains potassium for patients who are having concerns of low potassium level, which can be dangerous for the heart itself. As mentioned, we watch the potassium level because even if we're trying to maintain that potassium level, it could get to a point that we're retaining too much, and the potassium level is higher than normal as well. So we keep an eye on that while patients are taking these medications to have labs done often enough to ensure that we're in the normal range. Okay, we can go to the next slide, please. And as mentioned, these are some of the medications that we had mentioned that were developed to control diabetes. And during the testing, they made sure that it was safe for patients, and patients with cardiac disease were noted to actually have improved cardiac function with these medications. And that's why it says it works even without diabetes, to the point that now these medications are prescribed if a patient has heart failure symptoms, even if they do not have diabetes. But they were initially developed to try to prevent glucose intolerance and obesity. And the way that it works, as it says, make you pee, extra sugar and water, the way that it works is it works on the kidney system to allow you to expel sugar in the urine. We can go to the next slide. Okay. So as you can see, we have options on what to give to patients. Some patients will have, for example, all 4 of these medications if necessary to treat heart failure. And in some cases, they might start with 1 or 2 and see how the patient responds. The echocardiography, the ultrasound of the heart, gives you an idea of what the ejection fraction is, and then you repeat that to see if the function of the heart has improved. They can look at the motion of the heart, which is affected not only by the health of the muscle, heart muscle, but also the valves, as Dr. Guyo had mentioned. If the valves are failing and there's leaky valves, then you're not getting the proper flow of blood through the heart. instead of moving in one direction, the blood volume starts leaking in the opposite direction, which can affect the ejection fraction. But overall, the cardiac system also has blood vessels that supply the heart muscle. And if you have cardiac artery disease, then the muscle is not getting the oxygen it needs to effectively pump. So the pump of the heart has to effectively work in synchrony from the top to the bottom, and it has to have a smooth system of contraction and relaxation to effectively work as it's intended. And if the coronary arteries are blocked and you're not getting enough oxygen to one part of the heart, it's going to affect the entire pump system. So the coronary arteries, the valves, and the overall health of the muscle of the heart all affect the function and determine if a patient has heart failure or not. We can go to the next slide. So as mentioned, this is a little synopsis of how a patient can manage it on a daily basis. We set a goal weight, and the patient weighs themselves each day. They will be on a regimen of medications, including the water pill, the diuretic. And if they note when they weigh themselves that their weight is a little bit higher, we will have a discussion on whether to increase the diuretic that day or to maintain. Some patients only take their diuretic a few days per week. It's something that needs to be balanced. But of course, having one meal that's high in sodium will affect this too. So that's why it's very difficult to try to remain balanced and vigilant on what you're eating as well. So we tell the patient to call the clinic, and at some point, if they're having shortness of breath, to have no reservation about going to the hospital to prevent a serious development of symptoms. We can go to the next slide. So this slide just notes a few common questions that patients might have with heart failure. The question is it safe for me to exercise? And we always start with light walking. You know, we don't recommend you start straining immediately too much or walking up a hill, but to start light and see how much can be tolerated. The question that a lot of patients ask is, can I travel? Is it safe to get on an airplane? And most often that is safe to do. Vaccines are safe. It's still recommended to get the flu, pneumonia, COVID vaccines. And then while some of the side effects of the medications can be intolerable, as we had mentioned with beta blockers, this intolerance of activity because your heart rate won't match your activity level because it's being controlled to stay slow. Some patients may be inclined to just stop taking it on their own, but it's best to have a discussion. Check your vital signs, the blood pressure, the pulse, and to see if it's safe to discontinue before doing it on your own. We can go to the next slide. That might be the last slide, if I'm not mistaken. Okay. So as mentioned, we track the weight daily, and we let all the patients know that the symptoms to be aware of are shortness of breath, chest pain, and to really try to be adherent. They use this word adherent. The word used to be compliant, but it's been changed to adherent. To adhere to your medication regimen. That way, especially if there are any side effects or changes in symptoms or vital signs, that the healthcare providers, not only at the clinic but also at the hospital, if they review the medication list, that they can make their changes knowing that the patient has been taking all the medications as prescribed. Otherwise, if dosages are being missed, then it's going to confuse the practitioner on what they should do next to help the patient. Was that the last slide? It was. Okay. We're going to have a discussion to go over all the questions, but I'll give the microphone back to Dr. Wright for now. Oh, you got it.
You hold it and we'll hand them out. If there are any questions, great. It may not be working. Or maybe it is. I gotta put it close. Excellent. As I knew it would be. Any questions about heart failure or anything that they talked about coming up? Sir.
SGLT, how new is that?
The SGLT2s were developed when?
Yeah, 2 or 3 years. It's been, except in California where it was all the rage for a few years before that for weight loss. Yes.
Me. Thank you.
Thank you. And again, I'd like to begin by thanking the 2 doctors. This series is so wonderful for us as residents. My question is this. A year or so ago, I was diagnosed with severe osteoporosis, and as a consequence, I'm taking calcium supplements. It worries me because I know what calcium sometimes can do to the circulatory system and the heart, and I wonder what your opinion is of that.
So both Prolia and the calcium supplements, I know there's a concern that it can lead to calcification of the arteries. Even with vitamin D, and I don't know how much this has been researched, but the recommendation is to take vitamin D with K2 because they say that it diminishes the possibility of calcifying the arteries. And the truth is, I don't know how worrisome that is.
It's something to be aware of, but doesn't very often complicate things. It is something to be monitored. So, yes, ma'am.
I know a lot of practitioners, especially in California, are prescribing the vitamin D with K2. But again, I haven't seen research that proves that taking vitamin D without the K2 has any concern. I know I recently got my labs done, and I was deficient in vitamin D. Surprising. I'm indoor all the time. But the physician told me to pick up vitamin D with K2. And I don't know if that was just a reflex that they recommended that, or because I've checked for research and it has not been proven that vitamin D itself effectively leads to that calcification, and whether K2 improves that or reduces that chance. But it is on the market and it's advertised for that reason. And I don't know the answer to that.
Yeah, that's. Thank you. Any other questions?
When you talked about then prescribing ARBs, but I think you really were talking about prescribing ARBs for problem with the heart. For a long time, I have been taking one of those ARBs simply for blood pressure, to lower blood pressure, and I found that very few physicians ever prescribed it just for blood pressure, and I wonder if that's changing now. I believe in that as blood pressure control.
It's been an excellent addition to the antihypertensive, blood pressure control regimen. It certainly has. Well, I want to praise you all for coming down here on a day when it's a little threatening with the COVID about, and I appreciate that all of you are masking and distancing and that kind of thing, because we do have a little bit of COVID going on. right now. I want to thank you for the support of, in particular, these two physicians. In their 3 years, they've been out here a lot and had good experiences, they've told me. I thought they would, but what I've learned over the last few years is one of the greatest things about the experiences is the encouragement our patients, you guys who have used the clinic, what encouragement they receive from you guys, because you're supportive of the education process, and that makes a big difference, and I can see it's making a big difference in them. I appreciate, of course, their service, but they didn't have a choice. But okay, well, thank you all for coming.